Welcome to a roundtable discussion about care of the elderly in haemato-oncology, brought to you by eCancer TV in Barcelona, coinciding with the European Hematology Association meeting. I'm Gordon McVie, and I'm the managing editor of eCancer TV, and I'm a senior consultant at the European Institute of Oncology in Milan. On that end, Richard.
I'm Richard Sullivan. I'm a professor at King's College London with the King's Health Partner Integrated Cancer Centre, and I'm the lead on a joint initiative between King's and the European Institute of Oncology around oncopolicy.
Pierre.
Pierre Fenot from Paris 13 University, clinical hematologist, and I'm mostly involved in the treatment of myelodysplastic syndromes and acute myeloid leukemia.
Thank you. Reinhard.
Reinhard Stauder, hematologist from the Innsbruck Medical University, mainly involved in myelodysplastic syndromes and in geriatric oncology.
My near neighbor, in more ways than one, Mario.
Mario Boccadoro from the University of Torino, nearby Milano, and my main interest is multiple myeloma in elderly people, of course.
One or two oncopolicy backcloth points, Richard.
Well, the elderly and healthcare are probably the most critical issue facing developed countries today. And amazingly, despite the fact that nearly a third of the population across Europe is going to be aged over 65 by 2025, it's still very low down the agenda for most governments and most of civil society. It's still not recognised as a critical issue. So we have a rapidly ageing population. We have major issues around the economics of how we're going to pay for the care. And there are also rapidly changing social situations for cancer survivors and for the elderly healthcare. Individuals are having less children, and so there are less families around to look after elderly people. And we're actually seeing more and more people living alone and below the poverty line as well. Amazingly, I think the first guidelines coming out of, for instance, the USA weren't until 1996, specifically aimed at cancer in the elderly. And in terms of social policy at federal level, recognising the elderly as a vulnerable, specific population in the same way we recognise ethnicity these days, it's simply totally absent. If you look around Europe, these sorts of initiatives and policy recognitions don't exist. All good policy should come from evidence rather than opinions. And one of those critical areas to look at is obviously what's been going on, what's the views across Europe when it comes to ageism, concepts of ageism within management, within research, in MDS and AML. And the background to the literature really shows that ageism still does occur. There are places where there is really very good practice and where actually people are applying what we know about oncology and the elderly very well. But there's still plenty of countries and centres and networks for which cancer care in the elderly, whether it's MDS, AML or breast cancer or whatever, it's very poor. But it's still very, very poor. There's a whole slew of new targeted agents coming through, which means you can deliver therapy now which is tolerated even by the frailer elderly populations. And particularly when you look at the heme-onc community, there seems to be, compared to the existing literature on solid cancers, a much greater recognition of the cancer in the elderly and the use of these new targeted agents to actually improve outcomes and treat a much wider population.
So we want to make people listen, I think is probably the bottom line. The general issues that you've outlined, Reinhard.
In newly diagnosed cancer, more than 50% are older than 70 years. So which means we are talking about the majority of our patients in the meantime.
Yeah.
Treating elderly is complex because you have to consider comorbidities, you have to consider cognition, and these are the issues where hematologists start to consider, where they start to hesitate, which means, does the patient tolerate the chemotherapy? How should I consider the comorbidities, particularly heart insufficiency or renal insufficiency? And does the patient understand what the plans are? So which means, can I get an informed consent? These are two major points. An important point is the individualized treatment, which means you have to check the different dimensions, which are functional capacities, which is comorbidity, which is cognition, which is social support and nutritional status.
And you're not even mentioning the genomic situation surrounding the tumor, so which is what we've been thinking about in terms of personalized medicine for the last 2 or 3 years since Gleevec, I suppose. Pierre, you were saying that you're interested in myelodysplastic syndromes.
1/3 of the patients evolve to acute myeloid leukemia, but even if they don't evolve to acute myeloid leukemia, their prognosis is poor, and it's really a neoplastic disorder. I mean, those patients predominate in the elderly, so it's a good example. They can be roughly divided into those who are considered low risk of progression to AML, where cytopenias, mainly anemia, are the issue, and those that are high risk with a short survival. Now, when it comes to higher risk MDS, they have a very short survival. Assessment of comorbidities is crucial, and also the social environment, because those patients after transplant will need some support. So here, a geriatric assessment is really extremely important. Now we have the hypomethylating agents, which improve survival and are less myelosuppressive. And what is very interesting is that they can be applied to very old patients, and we regularly now apply them in patients even older than 80. Many people, even above the age of 80, can receive those drugs because they're not too myelosuppressive, they're relatively well tolerated. A crucial aspect is to have those drugs administered as much as possible at home, and tolerance is much better. And having enough cycles is crucial to improve survivals.
Because in the geriatric population, there is an issue with oral medicine. Of compliance. Mm-hmm. So this is taking the medicines to the patient in the community.
And I think that's crucial for the elderly. So in terms of compliance, of not wanting to stop the treatment, and so therefore optimizing the effect of such treatment.
The therapeutic scenario in myeloma has totally changed in the last 10 years, because the chemo remained totally unchanged for at least 30 years. It was the most famous melphalan and prednisone oral.
Medical Research Council trial, 35 years ago, British Medical Journal.
Then we had these new drugs, and then the survival of myeloma patients really changed. We moved from 3 years to 5, 6, and probably more. Younger patients below the age of 60, their survival is really improved. Yep. If you look at the other patient according to the age, is not improved in the different decades. You know, we have the same survival between 50 and 60, 60 and 70, 70 and 80. At that level, in the younger population, you see the curve that is going up because of the introduction of thalidomide, Velcade, lenalidomide, all these new drugs. On a population-based analysis, the elderly patient, at least in myeloma, I suspect, I don't have the formal proof, but I suspect that they are discriminated because they are not receiving the therapy. Of course, it's more difficult because the elderly people, they have comorbidities.
But it's also more expensive. And hospital budgets are restricted, and you have to choose who gets the expensive drugs.
But, well,
is that where the discrimination is?
That point should be discussed because, you know, the usual treatment for an elderly patient is the following. I start with melphalan and prednisone.
Not bortezomib.
Not the new drugs. Not the new drug. I give you the new drug when the patient will relapse. Yeah. So the patient stay in remission a short period and then is treated with the new drug. So the cost at the end of the day or at the end of the treatment is exactly the same, but the quality of life is totally different, and the remission period is totally different too. Of course, we have to do a lot of work, because if you are looking at the recent trials in the elderly patient, the rate of discontinuation is so high, is 40%. So it means that we need a protocol that are addressed to the elderly patient. We need an evaluation, a score.
So you're convinced that triple therapy works in older patients?
Absolutely.
Because that's an important message. I mean, one of the messages I've been hearing is that it doesn't seem to matter what your age is, you still deserve treatment. The treatment needs to be appropriate to your comorbidities and the aggressiveness of your disease, but you still deserve treatment. And if you can put your patients into clinical trials, you would do.